doctors. So today's topic will be on the systemic sclerosis. This is again a chronic autoimmune disease characterized by the accumulation of the material like collagen in the skins, in the vascular epithelium, and also in the internal organs. So that is a systemic sclerosis. So it's a multi-system disorder, like any autoimmune disease. So not only the skin, but also the kidneys, heart, lungs, gastrointestinal system, the brain. So all the organs will be involved in this disorder. So this is again a multi-system disorder. So exact cause is not known in any autoimmune diseases. It may be a combination of the genetic factors and the environmental factors. A thickening of the skin caused by the accumulation of the connective tissue. The connective tissue here, the accumulation of the collagen type 1 and 3. Involvement of the visceral organs. Most of the things in the systemic sclerosis, there will be involvement of the lung, involvement of the heart, involvement of the gut, kidneys, etc. So epidemiology, the peak age is between the 30, 40, 50. So between 30 and the 50 years in the Indian population. So younger age in the women and with the diffuse disease. If it occurs at the younger age group, so the disease is more diffuse. And the female and the male, 3:1. What are the environmental exposures to cause this systemic sclerosis in those people who are genetically predisposed? So silica exposure in men, there is an increased risk for that. Silicone breast implants, a contaminated oil in the spine, vinyl chloride exposure, bleomycin, and tryptophan. So these are some of the environmental factors which trigger the genetically predisposed individuals to cause the systemic sclerosis. So there is a familial clustering in this, about 1.5 to 2.5% of those with the first degree relatives. HLA haplotypes, there is a higher risk in certain populations. So this is the exact pathogenesis of the systemic sclerosis. There were an endogenous pathogens or the exogenous pathogens. They stimulate the antigen presenting cells. These antigen presenting cells stimulate the CD4 T cells. Then the cytokines are produced. The cytokines stimulate the growth factors to stimulate the fibroblasts to produce the collagen. So this is the 1 and 1 and 3 are responsible for this accumulation in the systemic sclerosis. Then the vascular damage occurs because of the thickened intima and then the narrowing of the lumen. So once the narrowing of the lumen, that leads to the ischemia. And ischemia leads to the prostacyclin production. It's a platelet aggregation and platelets bind to the endothelium. And that is a mycogenic for the fibroblasts. So this is all the pathogenesis of the systemic sclerosis. So here both the endogenous and the exogenous pathogens, they stimulate the presenting cells, antigen presenting cells, CD4 T cells, and also the, so this is the diagrammatic representation where you can sell the B cells and the T cells and the different tumor necrosis factors, interleukins, and finally the formation of the fibroblast, and there will be the platelet aggregation and the narrowing and endothelial dysfunction. So that is how the vascular inflammation will occur and the internal organs will be damaged in the presence of systemic sclerosis. So here the endothelial, you can see the endothelium here. So there is an cellular activation, adhesion, and the migration into the endothelial matrix. And the fibroblasts, in the fibroblasts there will be the recurrent endothelial cell damage. And finally that will lead to the endothelial dysfunction, narrowing, ischemia, fibroblasts, and finally the platelet aggregations. You have the two types of the systemic sclerosis. One is the limited scleroderma and the second one is the diffuse scleroderma. So this scleroderma is mostly of the dermatological manifestations, whereas the systemic sclerosis, you will have both the dermatological as well as the internal organs involvement. So systemic sclerosis, the limited scleroderma, the thin skin thickening is distal to the elbows and the knees, not involving the trunk. So that is the limited one. In the limited one, there will be the involvement of the hands, involvement of the feet, and involvement of the face. Whereas the abdomen and the trunk and the thighs and the arms, they are the spared. So the below the elbows, both the hands, face will be involved in the limited scleroderma. See the diagnostic criteria for the scleroderma. It is the American College of Rheumatology and also European League Against Rheumatism criteria. Here they have given the 8 points, and each one they have given about few marks about the 2, 3, 4 or 9, etc. And the patients with a total score of more than 9 are classified as having a definitive systemic sclerosis. And if you see the points wise, skin thickening of the fingers of both the hands extending proximal to the metacarpophalangeal joints, 9 points, 9 score. And skin thickening of the fingers, puffy fingers, 2 points. Sclerodactyly of the fingers, here the sclerodactyly distal to the metacarpophalangeal joints but proximal to the proximal interphalangeal joints, 4 points. Fingertip lesions like digital tip pulsars, 2 points, or fingertip pitting scars, 3 points. Telangiectasia, 2 points. Abnormal nail fold capillaries, 2 points. Pulmonary arterial hypertension, 2 points. ILD, the interstitial lung disease, 2 points. Raynaud's phenomenon, 3 points. And the antibodies, like anti-centromere antibodies or anti-topoisomerase 1, also called as systemic sclerosis 70, or anti-RNA polymerase 3. So one of these 3 antibodies, you can give 3 points. So this is how we have to diagnose the systemic sclerosis according to these points. The limited scleroderma, it's a more gradual process. I can have a Raynaud's for many years, even up to a decade. Whereas in the diffuse scleroderma, the Raynaud's phenomenon is only for the a few months or the years, because the disease is aggressively extending to the internal organs. Whereas the limited scleroderma, this is pertaining only to the mostly the skin, not the internal organs. Skin involvement distal to the elbows and the knees, often with the perivolar involvement. So here the skin involvement is to the elbows, knees, and to the mouth, face. Capillaroscopy with the dilated capillary loops but without the dropouts. Less organ involvement, as I told you, in the limited scleroderma. Even though 10 to 15% will have an isolated pulmonary hypertension, and renal involvement is very rare. And the antibodies positive in the limited scleroderma are anti-centromere antibodies in about 70 to 80% of the cases. See, this is the crest syndrome. C stands for the calcinosis, the calcium deposits in the skin. But if you check the calcium levels in the blood, they are the normal only. The second one is the Raynaud's phenomenon, because of the spasm of the blood vessels in response to the cold or the stress or emotion. And esophageal dysfunction, so there will be the acid reflux and the decrease in the motility of the esophagus. Sclerodactyly, that is the thickening and the tightening of the skin on the fingers and the hands. Telangiectasias, dilatation of the capillaries, causing the red marks on the surface of the skin. So this is the crest syndrome, calcinosis on the fingers, a Raynaud's phenomenon here, and the esophageal dysmotility. Here the telangiectasia, and then sclerodactyly. So this is the calcinosis, very common in the localized scleroderma, not in the diffuse scleroderma here. The night-fold capillaroscopy. In the diffuse scleroderma, it is a more rapid process, often with the onset of the skin thickening within a year of the Raynaud's symptoms. Skin involvement is proximal to the elbows and the knees, and almost whole body will be involved here, including the trunk, face, trunk, knees, elbows, both the lower limbs, thighs, arms. So total involvement will be seen in the diffuse scleroderma. Capillaroscopy reveals the dropouts. Early organ involvement will be here. Almost all the organs, internal organs, mostly the renal, pulmonary, cardiac, and also intestinal, often within the first 3 years. And here the antibodies, anti-scleroderma 70 and RNA polymerase 3 positivity will be seen in the diffuse scleroderma, whereas anti-centromere antibodies will be positive in a limited scleroderma. See, this is the diffuse scleroderma with the Raynaud's phenomenon, sclerodactyly, and then the flexon contractures, and then the trunk involvement here, the hand involvement distal to the proximal to the elbows, a trunk involvement, and if you see the lungs, the interstitial lung disease. So this is the diffuse scleroderma, almost all organs, and the kidney involvement, vessels involvement, cardiac involvement will be seen in the diffuse scleroderma. So common organs involved in the diffuse scleroderma are the skin, musculoskeletal, pulmonary, renal, gastrointestinal, the cardiac. Now skin involvement. So in detail, early stages and the late stages skin involvement can be occur. In the early stages, there will be the perivascular infiltrate, which are primarily the T cells, and skin swelling, which eventually becomes the skin thickening. It involves the hands and the feet, mostly the distal. In the late stages, the finger-like projections of the collagen extend from the dermis to the subcutaneous tissues to anchor the skin deeper. Skin becomes firm, thick, and tight. Skin thickening moves proximally. Fibroblasts and the collagen deposition. Hair and wrinkles overlying the area of the skin thickening disappears almost like a masked face. So the nose will be very sharp, and mouth will be very small, and the nasolabial folds will be disappeared, and almost the face looks like a mask, expressionless face. Skin involvement in the scleroderma may regress on its own over the years, a reverse pattern. So sometimes, starting with the regression of the skin thickening in the trunk, then the proximal extremities, and then the more distal. Distal ulcers on extensor surface of the proximal interphalangeal joints and elbows. Sometimes, it gets secondary infected also. And distal ischemia with pits in the distal aspect of the disease related to the prolonged Raynaud's, and thinning of the lips and beak like the nose. See the skin manifestations here, how the nose, and then the mouth. In the hands, there will be the ulcers there, and here the dry gangrene, distal gangrenes, and here angiogram shows you the total obstruction of the flow in the distal parts of the hands. In the musculoskeletal, these people may have the arthralgia and arthritis. Arthralgia is very common in the limited scleroderma, whereas arthritis is common in the diffuse scleroderma. More than 50% with the swelling, morning stiffness will be there, and pain in the joints of the hands. Carpal tunnel syndrome, contractures are very common in diffuse scleroderma. Polymyositis, once it is an overlap syndromes, this is also very common. Overlap with the systemic sclerosis is the myositis. Pulmonary is the leading cause of the death, since we are better at the control of the renal disease. So nowadays, with the good availability of the dialysis facilities and the renal transplantation, nowadays the most common cause of the death in these sclerodermas are the pulmonary and the cardiac. Symptoms: the exertional dyspnea with a non-productive cough is a very common symptom for the ILD. And the types of the lung involvement, mostly the ILD, are the pulmonary hypertension. Interstitial lung disease, the inflammatory phase with the ground glass opacities and the linear infiltrates. Usually here the involvement of the lung in the lower 2/3 of the lung fields and the high resolution CT scan. Fibrosis, the late phase with the honeycombing will be seen here. And the diagnosis pulmonary function test, mostly the restrictive pattern with the low FVC, low residual value, and low DLCO. HRCT is very important to diagnose the ILD, and ball and lung biopsies are not required. It is most commonly with the diffuse scleroderma, anti-sclero 70 antibodies. So the management of the pulmonary involvement, here the mycophenolate mofetil. So it's a very commonly used drug in the presence of the pulmonary involvement and systemic sclerosis. Azathioprine we often use as an outpatient, available in the two strengths, 25 mg and the 50 mg. Usually use 50 mg OD. Cyclophosphamide IV as a pulse therapy, about 15 to 30 milligrams per kg body weight. We can give once in a week or once in a month as a pulse therapy of the cyclophosphamide. And steroids are very sheet anchors in all the autoimmune diseases. Here also it is applicable here. And pulmonary hypertension, you can use the vasodilators. Again, like the sildenafil, there is a very commonly used drug here. And lung heart transplant is not possible in all the population. Yes. This is the overlap MCTD, that the mixed connective tissue disorders, myositis. Here sometimes you may need a muscle biopsy also to confirm the diagnosis. So similarly to the myositis alone with the methotrexate, azathioprine in combination of the low dose steroids. So methotrexate also can be used in the overlap syndromes. Suppose systemic sclerosis with rheumatoid arthritis. Obviously, methotrexate is the drug of the choice there. Tend to keep the prednisolone dose at around 10 milligrams or less to avoid the risk of the renal crisis. I told you, when I deal with the renal crisis, when the dose of 15 milligrams or above steroid is at higher risk of getting the renal crisis. This is the cardiac involvement. Pericarditis, we often use the NACRs, and drainage of the effusion if it is tamponade. Cardiac tamponade, definitely we have to go for the drainage through the Giffey-Sternal approach or intracostal approach. Myocarditis with elevated CKMB and the troponin, so more in favor of the coronary artery disease. So if the coronary artery disease is excluded, MRI and the biopsy confirms, then the treatment would generally be with the low dose prednisolone and the cytoxan, that is immunosuppressive drug, and nifedipine may also be useful provided if the patient requires it. So that is how we treat the myocarditis. Skin disease, stable disease, no treatment is needed, but advancing the diffuse skin involvement. So diffuse skin involvement, we use the methotrexate as a DMRD, mycophenolate mofetil, like your pulmonary involvement. Current trial with the tocilizumab. So that's the drug we often used in the corona period, COVID-19. We use this tocilizumab. D-penicillamine, 125 milligrams per day. And research on the various anti-fibrosis therapies is being performed. We often use the nintedanib. So that is also very commonly used drug to reduce the pulmonary fibrosis. So there is a different differential diagnosis: the scleroderma, scleromyxedema, diabetes, hypothyroid, nephrogenic systemic fibrosis, eosinophilic fasciitis, and graft versus the host diseases. So these are the different differential diagnoses. For example, if you take the diabetes and hypothyroid, it can be associated with the skin induration. So the chronic diabetes, the skin also very thick. And the myxedema also, you know that the skin will be very thick in severe myxedema individuals. In diabetes can have sclerodactyly, that is a diabetic iridoarthropathy. And poems, what is the poems? P stands for polyneuropathy, O stands for organomegaly, E stands for endocrinopathy, M stands for monoclonal gammopathy, and S is skin thickening. So this is hypothyroid myxedema cases. And eosinophilic fasciitis, the hands and the feet are the spared here, whereas the hands and the feet are very much involved in the localized systemic sclerosis. And peripheral blood eosinophilia is a very common in eosinophilic fasciitis. Pseudo orange appearance, and diagnosis via skin biopsy only. So graft versus the host disease, history of the bone marrow transplant, no Raynaud symptoms here, and diagnosis via skin biopsy only. So when you are in a doubt in systemic sclerosis, we need the skin biopsy to rule out these diseases. So this is the definite score, already I told you. But few things to be discussed at this juncture are telangiectasia. See, telangiectasias are visible, macular, dilated, superficial blood vessels. They are visible, macular, dilated, superficial blood vessels which collapse upon the pressure and fill slowly when the pressure is released. That is telangiectasia. The collapse on the pressure Then they fill slowly when the pressure is released. Telangiectasia in the scleroderma-like pattern are round. They are the round and well demarcated, and they are found on the hands, lips, inside of the mouth, distinguishable from rapidly filling spider angiomas with a central arteriole and from the dilated superficial vessels. So that is telangiectasias. What about the Raynaud's phenomena? Self-reported or reported by a physician with at least 2 phase color changes in the finger and often toes, consisting of pallor, cyanosis, and a reactive hyperemia in response to the cold exposure or emotion. Usually one phase is pallor. So that is the Raynaud's phenomena. So one phase is pallor. The second one is either cold, either blue or the red. So these antibodies already I told you, anti-centromere antibodies, anti-scleroderma 70 antibody, also called as topoisomerase 1 antibody, and RNA polymerase 3 antibodies. So now move on to the cases. These are very interesting cases. Please spare some of your valuable time here. This is a case 1. A 50-year-old female who has crushed syndrome with the anti-centromere antibody. Sirisha, you should answer this case. 50-year-old female has crushed syndrome. You know what you mean by the crushed. C, calcinosis, R, Raynaud's, E, esophageal dysmotility, S, sclerodactyly, T is telangiectasia. With the anti-centromere antibodies. Once it is anti-centromere antibodies means localized systemic sclerosis, not diffuse systemic sclerosis mostly. Okay. The Raynaud's controlled with the nifedipine. So we use the anti-vasodilators for the Raynaud's phenomena. Only digital skin thickening of the hands, which is unchanged. So skin thickening is only on the hands, not in the trunk, not in the thighs. Okay, if they are involved in the entire body, it is diffuse. Here the hands involvement is localized. GERT and omeprazole. So proton pump inhibitors for your GERT. Telangiectasia is there. She currently has no complaints. No complaints. Lab report. Your CBP, ESR, CRP, they are all normal. The anti-centromere antibodies are the positive. Echo and PFTs. Echo normal with a normal estimated PA pressure. That means no pulmonary arterial hypertension. Your systolic pulmonary artery pressure more than 30 is pulmonary hypertension. More than 60 is severe pulmonary hypertension. PFT usually restrictive pattern in scleroderma. Here it is the normal lung values and the normal DLCO also. What is the next step? So this is the history, mostly asymptomatic. Most of the labs are the normal except anti-centromere antibody positivity, and your PFT is the normal, no lung involvement, and echo is the normal, no pulmonary arterial hypertension or ischemic heart disease, etc. So nifedipine and the omeprazole the patient is taking. So this case highlights the most typical case seen in the clinics with a stable disease. Okay, so things to watch for. So what are the things to watch in the next follow-up visits? Change in any skin disease, change in the pattern of the skin diseases, or any progression of the skin lesions, periodical echo and the PFT to rule out any pulmonary involvement or cardiac involvement, and general examination, whether it is a converting to the diffuse scleroderma or not. So that is the first case. What is the diagnosis? First case, it is a limited scleroderma, a stable case with a normal lungs, with a normal pulmonary arterial hypertension, with anti-centromere antibody positive, with no other antibodies are the positive. Okay, so that is a very simple case and a stable case. What treatment you have advised there? You advise only proton pump inhibitors and nifedipine for your sclerodactyly or telangiectasia, for your crushed syndrome. Okay, now this is the case 2. Okay, now Supriya should answer. Here the 60-year-old male with Raynaud's for 4 months prior to the onset of the skin involvement. So here is 60. Is it male or female? Male. All autoimmune diseases, if occurs in the male, they are very, very aggressive. So male rheumatoid arthritis, very aggressive. Okay. So with Raynaud's for 4 months prior to the onset of the skin involvement. Skin thickening has ascended to involve the proximal extremities, chest, abdomen within 1 year. Okay. Is it localized or diffuse? Supriya. Now you are dealing a case of diffuse scleroderma. See the history. Okay. The patient reports the mild shortness of the breath recently. Okay. Exertional dyspnea. Okay. Non-productive cough. So more in favor of pulmonary involvement also. Okay. So what pulmonary involvement you can expect in systemic sclerosis? Maybe interstitial lung disease. Maybe severe pulmonary fibrosis. Maybe pulmonary arterial hypertension. Okay. So నీకు ఎప్పుడు అలా అనిపించే ఉండాలి ఇలా ఓ. So now the examination. See the vitals. BP 124/73. Okay. Pulse 80. So no tachycardia. Respiratory is 18. No tachypnea. Raynaud's noted without the digital ulcers. No digital ulcers at this juncture. But Raynaud's is there. But no ulcers. Cardiovascular examination is normal. No P2 loud. P2 loud means pulmonary arterial hypertension. Right ventricular heave means right ventricular failure. Okay. When there is a systolic murmur in the tricuspid area, pan-systolic murmur, tricuspid regurgitation. Okay. Or pulmonary regurgitation. So these are so common with the right-sided lesions. So they are not there. They are the normal cardiovascular examination. So when you are dealing a case of pulmonary hypertension, you are suspecting pulmonary arterial hypertension and examining the heart, which part of the heart you should look for? Is it left heart or right heart? Right heart. Okay. Right. You are absolutely right. Now the gastrointestinal system is normal. Dry cracks noted at the both bases. Okay. It's the lower 2/3 of the lungs are involved in scleroderma at the bases. Extremities, no edema. That means no right heart failure. Okay, right heart failure means edema, your JVP, hepatojugular reflex. So all these will occur there. Now the lab. So up to this, what is our diagnosis at this juncture? It is a diffuse scleroderma. Okay, with maybe a pulmonary involvement. Cardiac involvement 0, no. Gastrointestinal involvement, no. And extremities, no edema. That means no right heart failure. But probably pulmonary involvement. Now the lab. CBP, total CK, they are normal. ESR 35, CRP 1.8. So upper limit is 1. So there is a vascular inflammation is there inside. Anti-scleroderma 70 antibody positive. Okay. So is it localized or diffuse? Diffuse. RNA polymerase 3 is negative. So more in favor of renal crisis or no? Not possible. So not in favor of getting the aggressive renal crisis, because this antibody is negative here at the juncture. So what is the next step? Excellent. And HRCT. Okay. See here. PFT. TLC is decreased. So restrictive pattern. Total lung capacity is reduced. Vital capacity is reduced. RV decreased. DLCV is also decreased. So more enough the restrictive pattern. Okay. More in favor of your interstitial lung diseases. Bronchoscopy confirmed all cultures in the cytology is a negative. Echo, no pulmonary hypertension. Lung biopsy shown on the right. What is the diagnosis? What is the treatment? See the HRCT in the center. Ground glass appearance. Honeycombing. Okay. So that is your lung biopsy on the right side. So this case is ILD. Interstitial lung disease associated with the scleroderma with active inflammation. How can you say it is an active inflammation? What is your CRP? Yeah, good. The CRP is elevated here. So active inflammation. So left untreated, what will happen? So the people will have more morbidity and mortality. So what treatment should give in the active inflammation? Only steroid sufficient? Steroid plus? Excellent. Steroid plus immunosuppressives like mecafenolate, mafetil, or your azathioprine or cyclophosphamide, etc. So these are the very important. That's how you should clinch the diagnosis and you should know what treatment you are supposed to start. Mycophenolate, cytoxan, rejathioprin. So the prednisolone, 10 milligrams daily, and gradually taper it. Okay. Okay, Mahesh. So that is the case number 2. So first case, it's a localized scleroderma, a stable case where you have given on just an ibuprofen. Okay. And then in the second case is an aggressive case, a diffuse with a pulmonary involvement, interstitial lung disease. Here use the steroids up to the 10 milligrams and also use the mycophenolate mofetil or azathioprine or cyclophosphamide as and when required. Okay. Now move on to the 3. Bharat, you should answer. 50-year-old female presents with onset of the Raynaud's for the 1 year. Okay. Develop the skin thickening from digits of the hands to just distal to the elbows. She has noticed difficulty getting out of the chairs and lifting the objects overhead. See, that is the examination. Symptoms. Onset of the Raynaud's. Skin thickening from the digits of the hands to just distal to the elbows. She has noticed difficulty getting out of the chairs and lifting the objects overhead. So some involvement of the muscle. Proximal myopathy is also there. Okay. Okay, examination. Temperature normal, BP normal, pulse normal, respiratory rate is normal. Cardiovascular pulmonary examinations, they are the normal. Gastrointestinal normal. Muscle weakness of the thighs and shoulder regions is noted. Okay. No skin lesions other than the skin thickening. Lab. ESR, CRP all normal. PM SCL antibody positive. What is PM? Polymyositis. So it's a overlap syndrome. So systemic sclerosis with polymyositis. Okay. Total CK is elevated. So that means the muscle involvement is there. The AST and ALT, they are elevated. Up to 30 is the normal. So 3 times, more than the 3 times elevated, more than the 5 times elevated. So what is the next step? Good. Excellent. What is your name? Yes, Vasavi. Forget. Okay. See the muscle biopsy here. Okay. Muscle biopsy here and the MRI. MRI of the thigh. Biopsy of the thigh muscles. So what is the diagnosis? Yeah. No, the scleroderma myositis overlap. That is the diagnosis. So what treatment you should give? You should start the immunosuppressives also. And also the steroids. So methotrexate or the azathioprine and prednisolone 10 milligrams daily. So over the next few months, what happened, Vasavi? CK levels normalized. Prednisolone doses gradually tapered from 10 milligrams to 5 milligrams, maybe 2.5 milligrams also. And the patient's strength improves. So able to get up from the sitting position. So the proximal myopathy has gone. So this is how you treat the scleroderma with overlap myositis. Very simple drugs. But thing is you should diagnose it. That is very important. Now Snigdha, you should answer this case. 35-year-old female with limited scleroderma for 3 years, anti-centromere antibody positive. So it's a case of limited scleroderma. So suggestive of anti-centromere antibody positive. Okay. With stable skin disease involving the digits of the hands, new rash appeared 1 month ago, gradually worsening, no change in the last 1 week. Raynaud's have been quite severe, but not on therapy. Examination, temperature normal, BP normal, pulse respiratory normal. Cardiac, pulmonary, gastrointestinals are the normal, no edema. Skin, yes. Okay. So it's a localized scleroderma with digital infarcts. Okay. CBP, CM, ESR, CRP all normal. Anti-centromere antibody positive. Anti-phospholipid antibodies negative. Echo with bubble study negative. What is the diagnosis? What is the next step? So this is the digital ischemia due to Raynaud's. No internal involvement. Only the limited, only the skin is involved, but the Raynaud's phenomenon is aggressive here. So because of this Raynaud, there is the distal ischemia, and also the some gangrene formation is also going up. So what drugs you prescribe? So you prescribe calcium channel blocker like nifedipine. So the nifedipine 30 milligrams, close follow-up, and increase the dose of the nifedipine as the blood pressure tolerates. So increase the dose of the nifedipine according to the blood pressure. When the patient's blood pressure is normal, you can slowly increase the dose of the nifedipine also. If not responding, can start nitroglycerin patches or can start the sildenafil. So these three are the answers for your distal ulcers due to the Raynaud's. What are they? Calcium channel blockers, sildenafil, nitroglycerin patch. Nitroglycerin patch. So I have seen 4 cases. What are they? Sirisha told just a stable localized one. And then Supriya told it's in a diffuse systemic sclerosis with interstitial lung diseases. So you told systemic sclerosis with myositis overlap. And the last one told localized scleroderma with more of Raynaud's phenomenon exaggeration leading to the distal ulcers and how to treat it. Now Krishna will tell. Case 5. 55-year-old male with rapid onset scleroderma. Rapid onset scleroderma. Very fast. Okay. With Raynaud's for 6 months. Then skin thickening that spread to the proximal arm, proximal thighs, chest, abdomen within 1.5 years. Is it localized or diffuse? Good. It is a diffuse scleroderma. So when you are taking an history, you should ask yourself whether you are dealing a case of localized scleroderma or a diffuse scleroderma. This is a diffuse scleroderma because the arms are involved, thighs are involved, trunk is involved, face is involved. So whole body is involved here. So this is a diffuse systemic sclerosis. What is the onset? Is it small, slow and steady or rapid in onset? Rapid in progression. So yes. So when you are saying that it is a rapid in progression, you should also think of the internal organs involvement. Okay? You should search for the internal organ involvement also. Here the blood pressure. What is the blood pressure? Generally 110/70. Normal blood pressure. Has mild headache. Has noticed some swelling of the legs also. Headache, swelling of the legs. On examination, what is the BP? 160/105. Earlier, what was the BP in that patient? 110/70. Is it high in there? How much systolic, how much diastolic? Systolic, nearly 50 millimeters of mercury. Diastolic, how much? Nearly 35 millimeters of mercury. So that is the hike of the blood pressure here. So that could be the reason for headache. Headache. Okay, pulse is normal, respiratory is the normal. Cardiac, pulmonary, gastrointestinal exams are the normal here. Neurological examination is non-focal. There is only mild bilateral lower extremity edema. So lab, creatinine, how much? 2. Baseline creatinine earlier, 0.6. Earlier blood pressure is normal. Earlier creatinine was normal. Now the creatinine has gone up from 6 to 2. Doubled or tripled 3 times hike in the creatinine levels and hike in the blood pressure is also there. CBC normal, ESR and CRP are the normal. Urine protein plus RNA polymerase 3 positive. So what is the diagnosis here? Good. So this is the renal crisis. So it's an aggressive renal scleroderma renal crisis. So what is the next step? You give good treatment to the kidneys. So how to reduce the renal crisis? Here the 2 things. One is blood pressure reduction. So blood pressure reduction with which drugs? Your beta blockers, your calcium channel blockers, your diuretics. Good. ACE inhibitors are the drugs of the choice here, like captopril. So you have to use these drugs here. Okay. So this is the scleroderma renal crisis. Treatment, not outpatient, hospitalization. Hospitalization, because they may land up with the hypertension encephalopathy. They may land up with acute left ventricular failure. They may land up with acute kidney injury. Okay. So start ACE inhibitors, captopril with the dose escalation. Okay. So this is the skin coring.